Hey, Carla, does it take a few moments for the system to let everyone in? Okay, so we'll just get started here in less than a minute.
Yeah.
Okay, good evening and welcome to the third out of four in our first series of the TMFD Academy. My name is Gary Gallant. I'm with TMFD Financial, and Carla Fernandez from TMFD Financial is here as well. And we really want to welcome you and appreciate you taking the time to join us this evening and listening to our guest speaker, Dr. Tony Mancuso, who I will be introducing shortly. But prior to that, we want to thank our sponsor this evening, Mark Rosart from Rosart Dental Labs. And Mark's going to speak for a few minutes. After that, we'll introduce Dr. Mancuso and get on with the main part of the evening. So, Mark, over to you. Thank you.
Great, thank you, Gary and Carla and TMFD Financial for organizing this great webinar series. It's fabulous. Hi, I'm Mark Rosart from Rosart Dental Lab. We're a family-owned, operated business. So I have the business with my brother Eric and my sister Nicole. My dad started the business in '64, and yeah, I would say we're pretty passionate about dentistry. And the speaker tonight, Tony Mancuso, we've known him for a long time, worked with them, and consider him a friend of the business and also of the family. And we're really honored to be able to be part of this for this evening. So thank you again, guys. It's fabulous.
Great. Thanks, Mark. We appreciate your participation and sponsorship this evening. We know that many of you are interested in CE credits in addition to listening to Dr. Mancuso, of course, and Carla will speak to that at the end. But during the presentation, there'll be some polls that pop up. And so we ask you to participate in the polls, which aids us in being able to validate that you were here and you were on to the end. So, and please do stay on to the end so we can be assured of getting you the CE credit. So it's my pleasure now, pleasure and honor to welcome Dr. Mancuso. So just a brief introduction of Tony for those who do not know him. Dr. Mancuso graduated from U of T in 1985, just a few years ago. Maintained a general dental practice in Welland until just about 5 years ago when he turned it over to his daughter. In 2006, he received the award of Master of the Academy of General Dentistry. And in 2011, he was recognized with the Lifetime Learning and Service Recognition Award by the AGD. He's published numerous dental journals, given over 100 presentations to various organizations. In 2012, he was named Canadian AGD Dentist of the Year. Congratulations, Tony. From 1999 to 2009, Dr. Mancuso conceived, developed, and ran Millennium Aesthetics, a live hands-on program that taught dentists and staff aesthetic diagnostics and treatment. In 2015, he served as co-director for the University of Toronto Continuing Education Cosmetic Dentistry Mini Residency Program for practicing dentists. He was scientific co-chair of CARD-P for the 2015 and 2019 meetings, and currently serves as president of the Regional Niagara AGD Study Club. And I've got about 5 times more than that, Tony. No, we'll stop here. For questions and answers, if you can use the Q&A, which is likely at the bottom of your screens. We know that some of you may have your Zoom screens configured differently, but probably at the bottom of the screens for the Q&A. And Dr. Mancuso's intent is to answer those after the presentation. So over to you, Tony. Thank you.
Thank you. Let me start my share screen. There we go. You guys able to see that okay?
Yes.
Beautiful. Thanks, Gary, for the kind intro. You said you were going to keep it to under 30 seconds and you lied. Carla, thanks for the technical component of the evening. You know more about Zoom meetings than anybody else that I've ever encountered. And last but not least, Mark Rosart, thanks for the support of this evening. As Mark alluded to, I've known the Rosart family and have been dealing with Rosart Lab for well over 35 years. And as he indicated, we have a great relationship. If we did not, I would not be continually working with them. So Mark, thanks for all the years of support and great work. It's very, very nice to have a lecture series that TMFD have put together where it's a marriage between clinical dentistry, and obviously tonight is being pure clinical, and the business part of running a practice. As you know, success is really a marriage of both the clinical aspect and the business aspect of running a dental practice. And TMFD realizes that and has come up with this lecture series. So thank you for doing that. I've been a TMFD client for approximately 5 years now. And one of the reasons why I made the jump was that historically, I was the quarterback of my practice. I would have to run to my accountant, and then he would give me back some feedback. I would have to run to my lawyer. I would have to run to my financial management individual. TMFD is now currently my quarterback. And so I have one point of contact, and it's nice to make that one call or have that one Zoom meeting a month with that individual. And I know that I'm well taken care of. I don't want this to be a big sponsorship for TMFD, but I just want to indicate my passion and the happiness that I have in switching over to TMFD. Let's talk about tonight. Tonight, it's going to be purely clinical. I'm going to be talking about predictable and efficient provisionalization of the anterior aesthetic case. Like most dentists, I've tried numerous ways of temporizing my aesthetic cases. And I found that this to be the most predictable and most efficient. And I've been doing it well over 20 years. If it didn't work for me, I wouldn't be doing the same thing over and over and over again. So obviously I've had a tremendous amount of success with this technique. And this technique is often referred to as the shrink wrap technique. And I'm going to go into a tremendous amount of detail for those that like to do their own lab work. And hopefully you all have your eyes open this evening. I know some of you have been working all day long, but I'm sure you'll get through the next 45 minutes or so. I want to just disclose that I have no affiliations with any university, any products. On the screen, you'll see that there's a whole bunch of companies on the right-hand side. And I have worked with those products and those companies. They paid me honorariums for lectures that I've done for them. So I just wanted to disclose that. The slides that you're going to be seeing of the cases are slides of my patients. They're not anybody else's patients. And there's my contact information if you want to do a quick screenshot. The best way to contact me is through email. I answer my emails rather promptly. Don't call the office because then you'll never get a hold of me. For temporization technique, as Stephen Covey indicates in his book, begin with the end in mind, because worse than being blind is having sight with no vision. And what I mean by that is that you need to have a diagnosis for your aesthetic cases. I happen to have developed the dental aesthetic assessment form, and this is my aesthetic checklist. You can use whatever checklist you want, but at the end of the day, you do need to have a diagnosis and a proper treatment plan. And the importance of that is that your diagnosis is what dictates your laboratory script to the laboratory as to your diagnostic wax-up. The diagnostic wax-up is often referred to as the diagnostic aesthetic preview. And it's a communication tool with the patient as to the aesthetic changes you'd like to make for them based on their diagnosis. So I'm going to go into great detail on how I temporize these cases. Now, some of you are not really laboratorily inclined. You don't want to do your own lab work. For those of you that are like that, I would suggest that you write at the end of your script, after you've given them specific instructions on what you want the diagnostic wax-up to be like, which would include the incisal ledge position, the length of your central incisors, etc., etc. You can have the lab make the silicone putties that I'm going to be sharing with you in the next few moments. The extra hard silicone lab putty I typically get through Central Dental, and there's the contact information, but you can get it through other avenues as well. And so you've gotten now, I'm going to assume you've gone through your diagnosis, you've got your treatment plan, you sent your script to the lab with the study models and your mounting information, and they are going to create the diagnostic cast. Now, the beauty that Rotsart is doing now is the diagnostic model, they actually now scan it and they actually print it. So now I've got a hard copy of the wax up, because as you know, you drop the wax up and the wax chips and so on and so forth. So now you've got a duplicate in PMMA or whatever other material the lab actually prints it in. So you could either use the diagnostic cast or a plaster duplicate or the printed model and go around the gingival margins with either a lab knife or even a high speed under magnification. I would strongly recommend staying away from the wax or from the waxed up part of the dentition and just lightly score the gingiva. So here's a couple models, one from the lateral view, so you can see a little bit of how the plaster scored with a lab knife. At that time, I was using a lab knife. Now I would probably use just a handpiece, or better yet, I just ask Rotsart Lab to do it for me, and they do this for me. So they score the model. So once you've mixed up your putty and you put it over the diagnostic wax up, you let it set, you've taken the putty off after it's set, you've scored your model as is illustrated on these two photos. Here's the putty that I get through Central Dental Lab. You can get them through other organizations as well. So you take that out, and now you apply some tray adhesive to the internal aspect of the putty index. You get a little Vaseline and lightly cover the scored cast to act as a lubricant. And then you inject a light body PVS into the putty index and reposition it over the cast. And typically I would recommend tie it down with a rubber band and just let it set. And that'll take 3 to 5 minutes. Now, once it's set, take it off, mark your midline. So that's what it looks like after you've taken it off. There's the light wash of the polyvinyl siloxane, light body. And that gives you a really, really detailed replication of your diagnostic wax-up. So once you've finished your tooth preparations, you take your records, you've taken your full arch PVS impression, you've taken photos of the stump shades, you've taken a stick bite registration or a face bolt registration, all the various registrations that the laboratory is going to require to do this case. Then you clean the teeth with a chlorhexidine scrub. You could use something like Concepsa scrub. You can get that through Clinical Research Dental. And I would recommend, after you've scrubbed the teeth down, gently dry them off and get some form of isolation in there. It could be as easily as cotton rolls, if that's all you need, if you're only doing a couple teeth. But if you're doing a more advanced case, 8, 10, 12 teeth, then you may want to use something like an Optrodam or some cheek retractors. I often get my patients just to position the cheek retractors, and I get them to work. I get them to hold the cheeks because I want to see what I'm doing. So now, before we start injecting the bisacril methacrylate, that's what we're going to be using for our temporization, I recommend a couple things. Number one, before you put your tip on the cartridge of the bisacril methacrylate, bleed the gun. Make sure that both the base and catalyst comes out of the tip. Because if you don't do that and one of them is plugged and then you go to put the tip on, you may only be getting catalyst or may be only getting base. And then you're waiting at the 10-minute mark as to why the stuff isn't setting. Ask me how I know. So I've trained the assistants prior to putting the tip on the cartridge to bleed the gun. They ascertain that both catalyst and base is coming out. Now they apply the tip. And now I have the patient retracted. Everything is nice and dry. I've tried in the putty index in the mouth. And I try it in with the midline as a guide. And the reason I try it in is that I want to see if there's a path of insertion that will facilitate putting the putty index in the mouth. There's nothing more frustrating than having the putty index loaded with your temporary material, and then you put it in the mouth and you're fumbling and fumbling and fumbling. You don't know if it's down, seated all the way. You don't know if it's off half a tooth or whatnot. Again, ask me how I know. Everything that I'm telling you is based on mistakes that I have made in the past. And hopefully by sharing those mistakes, you could avoid them. So have a trial run at putting in the putty index, get your gauge as with the midline, look at it when it's fully seated to make sure that you're comfortable with it, and just pop it out and put it in a couple of times just as a trial run. Now you're ready to inject the bisacril methacrylate into your index. Again, don't go straight to the index. Get that tip and bleed a little bit on your tray cover. It does two things. Number one, it ascertains that the color is homogeneous and you're not getting too much of a catalyst or too much of a putty in the first little amount that squeezes out of the cartridge. And secondly, that will aid for you to check that the material is setting intraorally as well. You'll be able to check it out within a minute, 2 minutes, 3 minutes. So now you've positioned the loaded putty index over the teeth. You have the assistant hold it down. Excuse me. And you get a rubber tip and a cotton roll and just remove all the runny stuff before it starts to get really hard. It's a lot easier removing the excess runny material at this stage than when it's really hard and you have to basically drill it off. And you'll see a case where I actually did that, and it is a nuisance. So take your time, remove the runny material, cotton roll, then get a rubber tip and just go in approximately and just remove the excess bisacril methacrylate. And this is very important. Time it. Hold it in there for 3 minutes. And I hold it in there. After I cleaned it all up, I put my fingers on the putty index and I hold it in there for 3 minutes, making sure that 3-minute timer goes off. So these are the various materials that I've used over the years, and they're all excellent materials. I've used Luxatemp, I've used ProTemp Boron 3 from 3M. I've used Integrity from Dentsply. A whole host of materials. They're all excellent materials. Whatever is good in your hands. So here I am Injecting the putty index. When you inject the putty index, avoid lifting the tip out and putting it back in, out and in, because you'll incorporate a lot of air bubbles. Try to hold it within the putty index, close to the incisal tips as best as possible. And here it is with the midline marked and positioned properly, and we're holding it for the duration of 3 minutes. After 3 minutes, the timer goes off. I use the tip of a scaler and I tease off the putty index. Now, when you take off the putty index, those temporaries stay on the teeth, hence the shrink wrap technique. They stay on the teeth. If they don't stay on the teeth, then there's issues, and you have to look at why did they come off. Did you not wait the full 3 minutes? Was there contamination on the teeth, or too much Vaseline or something on the teeth? Whatever the reason is, the temporaries should stay on the teeth. Now, when you take off that putty index, inevitably, there's always going to be a little air bubble here or a little area that was missed, maybe at the gingival margin. So you fill those little voids with, I use Luxaflow or any flowable, obviously of the same shade. Fill in the voids, light cure it, and now you start the cleanup. You remove all visible flash with a scaler. I just get a scaler and then go around the non-prep teeth. There's always going to be a very, very thin, invisible surface of bisaccharomethacrylate on the adjacent teeth. It is so translucent that you can't see it. You'll have to scratch it off, and then you'll be able to see little flakes of it come off. And then I'll go with a 7901 carbide and just go around the margins gently. Don't go hacking away at your beautiful preps that you spent a few hours preparing, and now in your cleanup, you're a little too aggressive with the 7901. It's a very light, feathery touch. After you've removed all the gross material, clean up the interproximal area. The gingival area needs to be cleaned up really, really nicely, because you want the patient to use a rubber tip over the course of the 2-3 weeks that they are in temps to kind of massage the gingiva and make sure that they stay nice and healthy. Then you look at the occlusion, make any adjustments to the occlusion, and add any characterizations to your temporaries. I'll show a case later on of where I had to characterize gingiva, of all things, on my temporaries. And then you proceed to your polishing with discs, jiffy brushes. You can use polishing paste. And my favorite is a little chamois, little buffer at the end of the various brushes and discs that I use. And that gives it a real nice high gloss. So again, here I'm going to pictorially show you what I just finished saying. So after the 3 minutes in the top left, I'm removing the putty index. You can see some voids, specifically the 2-1, the distal incisal corner. And so I'm using, at the time, it's an old series. The flowable that I was using was Revolution. That kind of dates me as to the time. It was probably in the early 2000s, late 1990s. Filling the voids with that, light curing it, and then polishing it. In this case was there, as you see the date, 98. So here she is 3 weeks later. She was very diligent with her oral hygiene. The tissues are not red and edematous. She was able to use a rubber tip interproximally. And overall, she did a very nice job. So this is 3 weeks later. She was in her temps. And there's the before and the after of the case. And again, that was done in 1998. And here's her 2008 series, and she's still a patient, and she still has these veneers, and it's been a very long time now. But you can see the gingival margins are quite nicely maintained, and the porcelain's in good shape for that length of time. So that was just a quick preview of the shrink wrap technique if you want to make your own putty. But this is what I'm doing more and more these days. I get my study models, I send them to the Rotsart lab, and they do my diagnostic wax up, which is in the top left. Then they do a printed model of the wax up, which is on the top right. And then they do my silicone matrices. The one on the bottom left is the temporary index with a light wash, as I've described. The top right putty is a preparation putty index, and that I place on the teeth as I'm preparing, and I kind of use it as a guide to make sure that I prepared sufficient material for the lab ceramist to make the porcelain veneers or porcelain crowns. And the way they make this, you can do it one of two ways. Do it as a solid putty index, or sometimes they'll slit it. So you'll have an incisal layer you can peel back, a middle layer you can peel back, and then a gingival layer you can peel back. And then the final index, the bottom right of the screen, is an incisal edge putty index. And so I'll position that on my dentition just to look at, is the incisal edge of the final preparations within the confines of the incisal edges of this putty index. Again, just another way of helping me in my preparation. So this is that case that I was just alluding to. So we did the diagnostic wax up, we did the putty index. The top left screen is his pre-op photo. He had a large amount of bone loss traumatically from 15 years earlier, and he was not a good candidate for implants unless he was going to get tremendous bone augmentation, and he reconsidered it and decided no, he would rather not have gone through all the various surgical procedures. So he decided to go with a fixed bridge. But you can see if I were to extend the pontics way up to that collapsed labial plate, that the teeth would look very, very long relative to the 1-2 and 1-1. So obviously we have to have a little flange with pink porcelain. And so I used my Kerr Creative color kit to characterize that gingiva, and there it is in the bottom left. And I wasn't very happy with that. So I had Rotsart sent me their shade tabs for gingiva, and he returned a week later to assess the temps. All my anterior aesthetic cases, they all return at the 1 week appointment to reassess everything. And at this 1 week, I checked the shade of the gingiva, and we picked a new gingiva. And you'll see here the final prostheses, 4-unit bridge and a single crown on the 1-2 with a flange in pink porcelain. And again, obviously it's retracted, so it comes out at you, but with his lip in repose, it masks all of that. So maybe I did that for my own vanity as opposed to him asking for it. At any rate, characterization at the 1 week appointment is part of the ritual that I go through. Let's go through the whole process all over again, and maybe I can point out a couple other little tidbits in the shrink wrap temporization technique. And we'll use Diane, case number 2, to discuss this. So here are her pre-op photos, lateral views, retracted from the front. She's a crowded case orthodontically, and she did not want to go through orthodontics, and that's her purview. Here's the retracted views. And you can see the photography. You're going to see a couple cases I'm going to go through later on that I go through the same photography series for all these cases. I use the AACD photographic shots, 12 before and 12 after, and I actually augment it with a few other shots that I like to take. So these are the intraoral close-up views, frontal, right lateral, and left lateral, and the occlusal view to really give you a perspective of how much out of the arch form these anterior teeth are. So again, same thing. The diagnostic preview, the aesthetic preview, diagnostic wax up. Then from the diagnostic wax up, I happened to make the putty index myself that day. In the early days, I used to make about 80% of my own provisionalization indexes and preparation indexes. Now I do maybe 10%, and I let Rozart do the remainder of them. So there's the provisionalization index, the preparation index. There's the intaglio view with the light body wash. So at this point, Carla, we're gonna do our first question. So if everybody can just take a quick moment. Carla, we almost done?
I'll just give it another minute or so just to give a few more people a chance to answer.
Alrighty.
We're at 80% response rate, so we'll just give it another few
Sure.
moments. Okay, I'm gonna end the poll and I'll share the results.
All right. C is the correct answer. For those, the 47% that indicated A, both are true. Got to remember that the putty index is made on the diagnostic wax up, not the pre-op model. So it's not the pre-existing study model. It's made on the diagnostic wax up. Just to have a little clarification on that. Maybe the question wasn't put proper. Okay. Carla, could I get back on?
You should be able to.
It's not letting me.
I do see your mouse moving.
Oh, there it is. Okay. It had a little cat nap. Oh. There we go. Okay. So in this case, in Diane's case, because the teeth were malpositioned, a couple of things have to take place in your preparation. This isn't a preparation lecture, but I just wanted to point out, obviously, laser gingival recontouring, and ideally this case should have been full gingival surgery instead of just gingivectomy. Should have been full thickness ostectomy with gingival recontouring that way. And there's the occlusal view, trying to get some semblance of arch form. And that's how I use the preparation index. Just check to see whether, now again, this index is made on the diagnostic wax up. That's basically following the final restorations. So you gotta have to have your preparations within the confines of this putty index. And at the end, I'm just rounding off all sharp corners with the disc. Take my stump shade. And in all these instant orthodontic cases, you can notice that the preparations are a little bit more aggressive. You have to break contact because the 1-1 has to be brought into the arch form, and the 2-1 has to be brought out a little bit. The 1-2 has to be brought out a little bit. The 2-2 has to be brought in a little bit. And in order for the ceramist to do that, they need the interproximals broken. So again, before I take my impressions, if I'm nicking the gingiva, or in this case, because of the laser gingivectomies, I'm using some form of tissue management. I like the retraction pastes. This happens to be X-Bacil, and just apply it on with a wet pellet and leave it on for a good minute. And then you wash it off. And here's some other retraction pastes. The X-Bacils by Kerr, Traxident from Premier, and 3M SB has their own retraction capsules as well. After the retraction paste has been washed off, you do a full arch PVS with light and heavy body. That's my protocol. And again, what I do now, you can see I'm kind of using my fingers to retract. I'm having my patients hold those cheeks back with cheek retractors. That way I got an extra set of hands to steady these tips and cartridges. So there's the final impression, typical PVS. I'm doing a symmetry facial plane relator stick bite, and you get those through Clinical Research Dental. There it is there. And again, so what I'm doing first on the left side of the screen is I'm trying it in. I'm getting my orientation. Put it in, take it out, put it in, take it out. Do it a couple of times just so that you are comfortable with doing that. And then I don't even take it out of the mouth all the way. I've dispensed a second bleed of the gun on the tray, and then I go right into the putty index. It's only 4 teeth. I could quickly inject that, put it back in, position it, and hold it. Remove the excess using a rubber tip. And again, I would encourage you to use cheek retractors here, get the patient involved, and you can do a little bit more cleanup when you can see the end of the putty. And again, fill any voids as I alluded to earlier. And then I'm using a long carbide 7901 to remove all the excess. And there it is with a scaler. You could remove all that flash, the heavy flash with a scaler, but don't remove it so harshly that you're going to tease off the temps off the tooth structure, because they're not chemically bound. They are only shrink wrap. The friction of the shrinkage of the bisacryl methacrylate is what helps keep it in place. And also in this case, because you're going interproximally, they're all united together. So again, 7901, clean off all the excess. Don't be so aggressive. And there's the temps. I should have been a little bit more diligent interproximally. I wasn't so good. And that's the other thing that I really encourage you all to do is take lots of photos. It really humbles you when you look at your work on a big, huge screen and you see, oh, I didn't quite get that done so well. It makes you a better dentist when you do a lot of photography. So again, I'll reiterate, at the 1 week post-op of the provisionals, you take new impression for the laboratory if you make any changes, such as length or shape. If they don't like the incisal embrasures, they want change a line angle, they want to do whatever change that they want, and you have to make it on the temps, then you're going to have to take a model, an alginate of that, and send it to the lab. Otherwise, the lab is going to assume that their diagnostic wax-up is their blueprint. So again, at that 1 week, besides making any changes that the patient may want, I reassess the occlusion, I assess phonetics, and then I have the patient sign off. If you don't, have the patient sign off on those temps. Then when you put in the finals, and the finals are supposed to be a replication of the temps, and they start complaining about various aspects in terms of the anatomy, then, you know, what's your recourse? Whereas if they signed off, at least you can say, well, you know, you did approve them, and this is a reproduction of them. So you get a little bit more ground to stand on. Okay, we're up to question number 2. The provisionals are made after all preparations are finalized, all impressions taken, bite registration is taken, and photos of the stump shades are taken. And before loading the putty index, let me just get rid of this. Before loading the putty index, it is not required to practice trying it in to assess fit and path of insertion. Well, this should be self-explanatory. I'll give you guys a few minutes. How are we doing, Carla?
Good, just giving it a few more moments and I'm gonna end the poll now. And I will share the results.
Okay, perfect. C is obviously the correct answer. I want to share this with you all. This is a checklist that I had developed for Millennium Aesthetics many years ago. And to this day, I still use it for all my large cases, my anterior aesthetic cases. You should all take a screenshot of this and use some of it, all of it, or none of it. Totally up to you, but you have my full permission to use whatever parts of it that you deem necessary. I've broken all these cases up into 4 appointments: the consultation or the pre-op appointment, then the prep appointment, the insert appointment, and then the post-op appointment. And there's all the various boxes that you check off so that the lab isn't calling you and asking for an opposite or an opposing model or a shade. Ask me how I know. So that's happened many times. So here's Diane after the case was inserted. Again, it should have been a crown lengthening case for 21, but she didn't want to do that. So this is as good as you're going to get with just a simple laser. There's the occlusal view. You can see we were able to correct her arch form. The teeth were in various positions pre-op, and now we've got a nice arch form. And I just want to spend a moment on Essex night guard. So the day that the case is inserted and everything is finalized, the occlusion and so on and so forth, the assistants take a alginate impression and they go in the lab after it's poured and it's set, and they make an Essex, a thin Essex guard. And they come back a week later for their 1-week post-op, and they're all given this Essex. It's part of the case. I don't know if it's buried in the fee, but there's no extra charge for a night guard for these cases. But they all get this thin Essex. And I like it for 2 reasons. As you know, most people do not admit that they're bruxers. You have to practically claw it out of them for them to admit that they're bruxers. So I always say to them, this is free. It's your insurance policy, and I want you to wear it every night. It's very thin, very comfortable. It's not bulky. It's not prohibitive. And I get a lot of compliance from patients. And it does two things. Number one, when they come back, let's say in 2 or 3 weeks, if they're in hygiene, or the next time I see them, I always ask them to bring their Essex night guard with them. And I look at it. And if it's perfectly clean, then obviously they're not compliant, as we all know. But if there's little scuff marks in it, the degree of the scuff marks kind of tells me whether they're kind of beaten up on it. And so if they come back and it's got a whole bunch of potholes in it, then obviously this thin Essex isn't adequate enough for them. You may have to go to a larger gauge Essex or a laboratory processed night guard, because they may be real severe night grinders or bruxers. So that's the beauty of wearing something that is compliant, is that you can assess it. You can almost use it as a diagnostic test, if you will. So these are just a bunch of cases I'm going to just throw out, and I've tried to show before, then the provisionals, and then the after it's been inserted. And you can see that the technique that I've been using, the shrink wrap technique, is just the same over and over and over. And whether it's like 8 to 10 veneers, or in this case was 9 or 8, sorry, 8. And this is 12, and this bridge work. So even with bridge work, I still do the shrink wrap technique, utilizing the diagnostic wax up, putty index with a light wash, the exact technique that I've spent the last 35 minutes describing for you. And even my full mouth reconstructions. Now, often in these cases, I segmentalize it, so I'm going to have to do multiple putty indices. But again, the exact same technique. Here's another. And another, and here sometimes for the full mouth, just marking the one central midline is not sufficient for you to put this in and out without having the putty index lean over maybe a quarter of an inch one way or the other. So sometimes you'll have to put multiple markings in order to help you in getting the insertion of the putty index seamlessly. And there's Dale's final case. And again, this is a full mouth reconstruction done over multiple segments. It's another, it's an upper arch reconstruction. Again, the provisionals are all shrink wrap technique, utilizing the exact same technique as I've described. There's from the frontal view. Again, when you look at these photos, you can see the interproximally. I did not spend enough time cleaning out that bisacral methacrylate. I should have been a little bit more diligent in that. And can you do it on lowers? Of course. Here's a case where it was lower anterior crowding. She did not want ortho. She is like 75 at the time, and she wanted instant gratification. We had done the uppers, and now she wanted to have the lowers done. So there's the diagnostic wax up, the diagnostic preview. There's the preparation index, the way I use it in the mouth, just to check to see my preps. And then there's my putty index wash. Obviously, when it's that clean, you know I didn't do it, but the Rotsart lab does it. And there's the temps in the mouth. Okay, question number 3. The materials used in this provisional technique often involves a bisacryl methyl methacrylate. The length of time to allow it to dual cure is
a few more moments and then I'll end the poll.
Okay.
Okay, and there are the results.
Beautiful. Good. I think I got that point through. Okay, I'm just gonna show a couple cases of interesting uses of the temporization technique. So here's Mallory. And Mallory came in for a consultation. She did not like her diastema. She got beautiful teeth, a bit of an overbite, a beautiful anatomy, but she hates her diastema. She does not want ortho. So this is the series of photos that I use for all my cases. This is the AACD, except for these 3 slides, and that is frontal retracted inocclusion, left lateral inocclusion, and right lateral inocclusion. The AACDs has the teeth apart to look at the incisal edge positions. So again, we'll go through this case rather quickly. There's the close-up of the teeth that are going to be treated, and there's the occlusal view. And the
Sorry,
lower.
Dr. Mancuso, the screen hasn't changed on our end here.
Oh, it's not.
No,
Do you see that change?
no, that hasn't changed.
Okay, so how do I? How about now?
It's still on the same slide. Oh, there we go. Now
Okay,
it's
hold on.
changed.
Let me. Did you see that?
So it's back on the original slide, but it was moving just a moment ago.
Do you see that change?
No, that hasn't changed on our end.
Okay, then let me see if I can do it this way. Do you see the change now?
No, unfortunately.
Okay.
It did work just about 30 seconds ago when we saw, I think it was F, the picture. But then it flipped back to the same slide.
So you don't see any of that changing?
No.
Okay, then we'll forget about it. Okay.
Yes. So now we see Bev on the screen.
Okay. So I'll describe. So one question that often is being asked is, okay, your preparations involve the interproximal, so I can see how the shrink wrap technique would work in that case. But how about if you have a very conservative preparation design, almost like feldspathic porcelain preparations, where you're not breaking contact? So what do you do in that situation? Well, you do the exact same thing with the following change. Before you load your putty index and go intraorally, what I ask you to do is go to every tooth, that's very, very conservative, and on the mid buckle, just put a little dot of acid etch, leave it on for about 10 seconds. So on every preparation, mid buckle, a drop of acid etch, phosphoric acid, clean it off, a drop of bond, like curate. Now get your putty index loaded with the bisacril methacrylate, and now follow through with the same procedure that I've outlined for you. Leave it on for 3 minutes. And when you remove the putty index, that little spot tacking should be sufficient to hold your temps in place. And that's usually what I do in those type of cases where I'm not going to get frictional lock in approximately because I have not broken the contacts. So hopefully that was clear. Let's look at another case, Bev. And here's Bev. She's got congenitally missing laterals. She's got a retained deciduous tooth. She's class 3 skeletal. She's got incisal breakdown, upper centrals and lower anteriors. And she was an orthognathic case. Her son went through orthognathic surgery after orthodontics for 3 years. And she made a plea with me. I don't want to go through what my son went through. Is there anything you can do? So basically we follow the exact same ritual. We do a diagnostic dental aesthetic assessment review. We do a diagnostic wax up. Take all of our photos. Look at the midline, it's off by quite a bit, but there's the diagnostic wax up. The midlines are still going to be off. And there's her final case, and we did that 2000. Lateral views, exact same thing. Same temporization, before and after. Before and after. Okay, question 4. The provisionals are removed from the mouth, trimmed, separated into individual units, and then put on back. Individually, critical area to remove excess temporary materials in the gingival embrasure area to allow for rubber tipping.
We'll just give it another 20, 30 seconds or so.
Yep.
Okay, I will be ending the poll and sharing the results.
Perfect. Okay. And the 5th and final question.
I will be ending this poll and sharing the results.
Thank you. Good. Okay, I'm gonna see if I can go back to that one. I want to just try. Are you able to see the screen now, Carla? Carla, are you able to see the screen now?
Sorry, it's still on the slide for question number 5.
Okay, all right. So again, to reiterate, although I spent the evening just discussing one specific aspect of anterior aesthetic dentistry, and that's the provisionalization, it is paramount that you arrive at a diagnosis and a treatment plan. The diagnosis starts with an aesthetic evaluation. Use whatever evaluation you're comfortable with. This happens to be the one that I have and developed for Millennium. You're welcome to utilize it. Take a screenshot if you want, but you should really have that if you're doing these type of anterior cases. There's the back of it. It goes over patient's concerns, their chief complaint, what your proposed treatment plan is, the cost for proposed treatment plan, and then if they're accepting treatment or not. And again, I feel so strongly about my checklist that I'm showing it a second time. Do yourselves a favor. If you're doing advanced dentistry like this, you really owe it to yourself and your team to have good checklists so that things aren't forgotten, especially in a busy practice where everybody's helter-skelter and you're bound to forget certain things. And with that, I'd like to thank Carla and Gary and all of you for spending the evening, the last hour or so with us. If you have any questions, take a screenshot, email me if I don't get to the questions that Gary's going to read out for us. And if you have anything specific you'd like to address with me, by all means, I'm at your disposal. Gary, it's all over to you.
Sure. So there's some questions here, Dr. Mancuso, that I'll read out, and hopefully I do okay with the pronunciations here. So from earlier, once the temporaries are on, how do you remove them? Are you using any cement to keep them in place? If not, how do you remove the temps before cementation of the final restorations?
Okay, that's a great question and gets asked all the time. These are shrink wrapped. They are not bonded on. So typically the way I remove the temporaries is I cut them off. And the way I cut them off, I have a protocol that I utilize. I always have a model of my preparations because the laboratory is always going to duplicate my preps model. One, they have the restorations on, and then they have a secondary model. And I utilize that chair side. I look at it, see where I've got space, and I start slicing interproximal. Because typically most of these cases require some degree of interproximal reduction. And then I just gently, based on the model, go through the middle of each tooth and go down the incisal a little bit, but I don't go down to the tooth. I try to avoid going down to the tooth. And then I use the heel of the sickle scaler. And I just go mid-incisal where I made my cuts, and I just torque it. And before I torque, I always tell the patient, you're going to hear some clicking here. I'm not breaking your teeth. I'm removing your temporaries. I'm cracking the temporaries. And I just click, 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 and then remove them section by section or piece by piece. Sometimes 2 or 3 come out at one time. Others, you have to spend some time interproximally, especially if it's a little bit sub-G, and really clean it out. And you have to take your time in those. Don't go hacking away. So hopefully I answered how to remove them.
What kind of camera do you use, and any special light?
You know what? That's a great question. I used to have the Yashica Dental i3 when it was back in the old slides days. It was the best dental camera I ever had. And I've got maybe 3,000 to 5,000 photos that I digitized that were actual slides. Today, whatever my daughter has just purchased recently at the office is what we're using. The best people to contact for the quality cameras would be Rita Bauer at U of T. I know she's retired now, but I'm sure you can get a hold of her through various means. I don't know specifically the camera that we have right now, but the old true tried favorite was a Yashica Dental i3.
Okay, I would love to see the checklist that you used for the lab again. I'm not sure if that's one that you were able to bring back up, Tony.
No, that was the
not.
second last slide.
And if we're not able to get to it, then if you're not able to bring it up, then anyone wanting that, Carla, they could send an email to, is it TMFD Academy?
Or even just send me an email and I could email it to them.
Or yes, academy at tmfd.ca.
Academy at TMFD.ca. Great, thank you. Next question, what thickness is the Essex night guard? Do you give it for the lower or the upper arch?
I always give the Essex guard over the dentition that I prepped. Typically it's the maxillary, so it's over those restorations. And the gauge is, it's the smallest one. I think it's an A+, and I think it's about 1 millimeter.
What's your technique for, oh, my screen moved on me here, sorry. What's your technique for removing the provisionals after using the shrink wrap technique? In my limited experience, I find it very tedious removing the temps and spend a lot of time with the handpiece and crown remover instrument. Is there an easier and faster way? Thank you.
I've kind of reiterated it or went through it already. I've answered that question. I'll just re-emphasize, use a long, thin diamond, use high speed, cut dry, have your assistant, if you're cutting from labial to palatal, have your assistant hold the high volume suction labially. If you're cutting from palatal to labial, have your assistant hold the suction lingually or palatally. And again, use your model of your preps as a guide so that you're not dinging the teeth. And just take your time, make all your cuts proximally, and then go through the middle of every tooth. You should know the amount of incisal reduction so you can go down incisally. And then, like I said, use the heel of that scaler and just torque it left, right. And if they're not cracking, that means that you have not gone deep enough on the bisacromethacrylate with your thin, long diamond. So just go back again. So it may take you a couple minutes. It's tedious, but you can't just go in there and blunder those teeth. Hopefully I reiterated it.
Okay, I'm going to just go through them in order, Tony, and apologies if some of them might fit together here, but how much removal of the temp material is needed in the embrasure space and in the interprox area to permit proper and adequate gingival hygiene while the PT is in the temps?
Yeah, so that's a great question. You got to look at your preparations before, and then when you put your temps on, you'll be able to get an idea as how much of that bisacromethacrylate is right on the papillas. If there's a lot of bisacromethacrylate on top of the papilla, then you got to gingerly go in there with that 7901 carbide and follow. I usually do a V-shaped cut on either side of the papilla to spare the papilla. You're not going to do a papillectomy, and just gingerly go in there. You don't have to be ultra bang on, because the temps are typically only on there for 2 weeks. They're not on there for 6 months or 3 months. If that's the case, you may want to venture into laboratory processed temps that you do use something like a temp bond on so that you can tap them off if you have to make any adjustments, or if there's surgery involved, or some other specific item on that specific case.
Okay, just about 5 more questions, Tony. What instructions do you give to the patient?
Basically, do whatever they normally do, except the following. Don't floss in between these teeth. These teeth are all joined together. They're done like that on purpose. Your final teeth, unless there's bridge work, will be individual, and you will be able to floss them individually. Avoid any crunchy stuff like ice, peanuts, walnuts, anything of that. Just normal postoperative instructions that you would give on after any crown and bridge, and then instruct them on rubber tips, just gently massaging the papillas interproximally and rinsing in normal oral hygiene. There's really nothing exorbitant beyond that.
Okay, next one. For vital teeth, do you desensitize?
To be honest, I don't. I can't remember the last time I've desensitized. The last time I desensitized was probably in the early 2000s when it was in vogue to desensitize. And I think the pendulum has swung, and I don't use any desensitizers. The only thing I'll use if I'm doing restorative dentistry and the restoration is going to be deep, I do use glass ionomer.
Tony, a question on the Essex material again, and I know there was a similar question earlier. I'm not sure if it was answered. How thick is the Essex material?
I think it's 1 millimeter. A Dentsply or a Raintree A+, and I think it's the lowest gauge, and I think it's 1 millimeter.
What is the specific reason for scoring the diagnostic wax-up cast prior to temporary matrix fabrication?
That's a great question. So what you want to do is you want to have a real tight fit of your bisacral methacrylate to your preparations. And what that scoring will do is will push the light body against the gingiva. The gingiva is pliable. So therefore, you're going to have less thickness. So it's easier to clean. Because if you have an inch, or I'll rephrase that, a millimeter of bisacral methacrylate to cut off, that's a lot harder than if it's paper thin. And so by scoring the model, you're going to be adding light body into your putty index, which will push against the gingiva and will give you a tighter seal of your bisacral methacrylate and easier to clean. Hopefully I described that.
Okay, 2 more are here in the Q&A. Can you please reiterate why you score the gingival margin on the wax-up diagnostic model?
I just did that. I just answered.
Okay, that one's done. Okay, thank you. 1 more. I noticed one of the provisional matrices in a case had been trimmed to follow the gingival margin scallop versus the majority of matrices were just a broad matrix with no trimming. Is there one you prefer and why?
Yeah, I actually do like it scalloped following the gingival margin so that I can get my rubber tip pointed interproximally and remove as much of the bulk of the excess bisacral methacrylate as possible. When it's just right across, maybe 5 or 6 millimeters beyond the gingiva, beyond your preparation, you're going to have a lot more excess to clean off. So the more you clean off ahead of time, the less your cleanup will be afterwards. So I do prefer the scalloped putty indices over the non-scalloped ones.
Okay, I see there's also a question in the in the chat, and I don't know if this has been answered, Tony. Do we use temp bond to cement the provisionals?
No, they should not be cemented with anything because they should stick to your teeth in the shrink wrap technique. If they do pop off, especially in very conservative feldspathic type cases, then as I alluded to earlier, you may have to spot etch, bond, cure, and then add a little bit. If you're lifted your putty index off and one of the temps came off with it, then get that temp, clean it up, and then add a little bit more Luxaflow in the interior of it, place it, use a rubber tip to clean any excess, and cure it.
Okay, I believe that's it for the questions. Dr. Mancuso, thank you. Thank you
Hey,
for
my pleasure.
participating in this. And thank you for sharing your learnings, your knowledge. Throughout the session, the attendee count went up, actually. Oh, Carla's signaling to me. Is that another question?
We just had another
You have one
question.
more? Okay. I'll read this question, then I'll finish the thank you, Tony.
All right.
When you do the light body wash on the wax up, are you letting the set first and then use the putty to make a matrix?
Just read that again.
When you do the light body wash on the wax up, you are letting the set first and then use the putty to make the matrix, question mark.
Okay, so get that in reverse. You do a putty first. You take the putty off. You put adhesive inside the putty. Then you put a little Vaseline on your model, your wax up. You inject the light body inside the index. That's already been set. The putty has already been set. And then you replace that over your wax up and put a rubber band around it.
Okay, that's it for the questions. Again, Tony, thanks so much for your expertise, your learnings. As I said, the attendee count went up, and lots of questions to which reflects obviously the interest in what you've presented. Also, thank you for your kind words on TMFD in your introduction. Thanks also to our sponsor, Mark Rotzart from Rotzart Dental Labs. And I'm just going to give a real quick plug for the next TMFD Academy webinar, which will be on Thursday, November the 18th. And Steve Farinato from TMFD will be presenting. And the subject is preparing to sell your dental practice, something that we know is of interest to many. And then please also watch for our 2022 dates, which we will be releasing in the next few weeks. And finally, Carla is just going to comment on the CE credits, and then we'll say good evening.
Thank you, Gary. And thank you again, Dr. Mancuso. So yes, for the CE credits, an email will be sent out to every individual who attended this evening, no later than November the 5th. So we'll send out a personalized email. If you do, however, have any questions in the interim, please feel free to email me at academy@tmfd.ca. Thank you again for everyone who joined us this evening and for our speakers and our sponsor. And we look forward to seeing you again in a few weeks.
Carla, did you want to say anything about the book? Is it still in publication?
Oh yes, the book is it's actually off to the printers, so we will be receiving our copies of our book, our latest book, in the coming weeks. So if you are interested in getting a free copy and reserving a free copy of the book, you can visit our website, tmfd.ca, and there will be a form there to reserve a free copy of the book. Thank
Great.
you for mentioning that. I appreciate it.
Thank you, Carla. Thank you,
Yes,
Gary.
thank
And thanks to Mark. And thank you, everyone, for attending tonight. Good night.
Thank you. Good night.